very important guideline, which is Management of Endometrial Hyperplasia. This is guideline number 67, and this was released in 2016. So endometrial hyperplasia basically is of two types, and this again is a very important topic. For sure, you'll get one EMQ or some SPAs related to this topic. So endometrial hyperplasia has been classified basically into two groups. One is hyperplasia with atypia, and the other is hyperplasia which is associated with atypia or atypical hyperplasia. Now, hyperplasia without atypia will usually regress in most of the cases, and less than 5% cases there is a risk of progression to malignancy. This is hyperplasia without atypia. But if it is atypical hyperplasia, then the risk of malignancy is very high. Then the risk of progression to malignancy can be as high as 25% to 33%. So these are the cases where you have to be really careful. These you can kind of observe, but this you need to be very, very careful, because the risk of progression to malignancy is very high. So endometrial hyperplasia diagnosis requires histological examination, and this is usually through diagnostic hysteroscopy, which may be done on an outpatient basis, and while you are doing this hysteroscopy, you can also do the directed biopsy of the area. Transvaginal ultrasound helps in diagnosis in pre and postmenopausal women both, because it'll tell you about the endometrial thickness, and from there you can then, if you feel the thickness is very high or there's some abnormality, then you can go ahead with a biopsy and hysteroscopy. Direct visualization and biopsy of uterine cavity using hysteroscopy should be undertaken for polyps or focal lesions. Endometrial hyperplasia without atypia has a minimum chance of progressing to endometrial cancer, with the majority of cases spontaneously regressing. So I discussed this previously, and I told you that hyperplasia without atypia, the progression to malignancy is very rare, and so simple with observation, majority of lesions will regress. In women who do not show regression of hyperplasia without atypia, you need to give them progestogen therapy, and the first line of treatment is LNG-IUS. So LNG-IUS, this is the first line therapy. I just spoke about this. But those who refuse LNG-IUS, they can be given continuous oral progestogens. Cyclical progestogens should be avoided because that is associated with a lower efficacy rate. Women who have a BMI of 35 or higher, because these are the women who will be at a higher risk of endometrial cancer, or those who are taking oral progestogens, they should have follow-up with the help of 6-monthly endometrial biopsies. And once 2 of these are negative, then this can be followed up with annual biopsies. Hysterectomy is recommended for women who do not want to preserve fertility. So especially if there is atypical hyperplasia, then hysterectomy is recommended. But even with hyperplasia without atypia, in women who do not want to preserve their fertility, you can go ahead with a hysterectomy. And in these cases, laparoscopic approach can be preferred because this is associated with shorter duration of hospital stay, lesser pain, and quicker recovery. Women with atypical hyperplasia should undergo total hysterectomy, and there is no benefit from frozen section analysis or lymphadenectomy. Postmenopausal women with atypical hyperplasia should also consider bilateral salpingo-oophorectomy in view of increased risk of ovarian cancer. So now this flow chart, it tells you about How to manage cases of endometrial hyperplasia with atypia. These cases are more important because the risk of progression to malignancy is high. And in majority of cases, what you want to eventually do is to go ahead with hysterectomy. But you may have cases where the women want to preserve their fertility. So if fertility is not desired, if she's a postmenopausal woman, you go with total hysterectomy with BSO, and laparoscopic route is preferred. But if she's a premenopausal woman, then you can go ahead with TAH or a total abdominal hysterectomy, and decision whether you want to go ahead with BSO or not needs to be individualized, because she will have, if you go ahead with BSO, she may have premature menopause. And bilateral salpingo-oophorectomy may be considered due to reduction in the risk of future ovarian malignancy. So you want to weigh the risk. If she is at a high risk of developing ovarian cancer in future, then you can go ahead with a bilateral salpingo-oophorectomy. Now, suppose fertility is desired and she wants to preserve her uterus. In that case, she should be counseled about the risk of underlying malignancy, and she needs to be told that eventually she must get a total abdominal hysterectomy done. Pre-treatment investigations to rule out invasive endometrial cancer or coexisting ovarian cancer need to be done in these cases. And you also must plan an ongoing endometrial surveillance. So in these cases, you need to do a regular follow-up through endometrial biopsy to ensure that there is no progression to malignancy which is occurring. And when they want to preserve their uterus, the first line of treatment is LNG IUS. And in case they don't want that also, then the second line of therapy is use of oral progestogens, which could be in form of medroxyprogestogen acetate or norethistone. Now, once they have taken this and fertility is no longer desirable, then in that case, she must undergo hysterectomy due to high risk of disease occurrence. And in case even after LNG IUS or oral progestogen, she still desires fertility, then you can do a follow-up with endometrial biopsy after every 3 months until 2 consecutive samples are negative, and then you can go ahead with an annual surveillance. So again, if regression occurs, long-term follow-up with endometrial biopsy every 6 months or 12 months until hysterectomy is done. If there is no regression, then she should be counseled to get an immediate hysterectomy.